presentation regarding unrevealing the mystery from ascites to constrictive pericarditis. Dr. Chayan Singha.
Honorable judges and dear moderator and learned audience, very good morning. I would like to present a very simple case, but sometimes to diagnose it requires so many times. So my title is Unveiling the Mystery from Ascites to Constrictive Pericarditis, a Patient's Journey. My patient, a 23 years old garments worker, he presented to us with the complaints of shortness of breath and palpitation for the last 2 months. His shortness of breath was progressive and associated with abdominal swelling, generalized weakness, and significant weight loss, but no history of fever, cough, hematomesis, malaria, or allergic disorder. He also complained of palpitation that was exertional and no other features of thyrotoxicosis, pheochromocytoma, and others. On background history, he developed gradual swelling, abdominal swelling, generalized weakness, and dyspepsia for the last 2 years after COVID-19 infection, for which he underwent thorough investigation, but he treated several physicians, admitted twice in hospital, but no diagnosis was reached. So, in our BSMU, he referred from hepatology department to our cardiology department. In our department, while he admitted into our department, when we examined the patient, he was icteric. His pulse was 72 per minute regular, but relatively low volume. He had bilateral pitting edema. JVP was raised, and there was a pericardial knock, which was found in the between apex and left lower parasternal. He has mildly understandable liver with moderate ascites. So the diagnosis, when the pericardial knock is present, so diagnosis is obvious, like it may be constrictive pericarditis. In the hepatic department, there was a lots of investigation was done, but there was no conclusive hepatic diagnosis was raised. In our cardiac department, we do first an ECG, where P mitral was noted. So it's a LA fissures was LA enlargement was assumed, and this is the chest X-ray posterior view and lateral view. It is showing the extensive calcification, axial calcification. It was seen both in the PA and lateral view. So, and while doing an echo in the left parasternal long axis view reveals the LA seems to enlarge, pericardium seems to be thickened, and this is the zoom view revealed the pericardium seems to thicken, and there is the abnormal motion of the septum. LA is enlarged, and there is a mildly reduced LV systolic function with septal posterior wall seems to little bit flatten. And pericardium was measured. That was actually ideally measured by transesophageal echo or better delineated by CT, but we measured it was seems to 6 millimeter. In the short axis view, there was a jerky motion of the septum was noted. In the long fourth chamber view, apical fourth chamber view, in the zoom view, there was a septal bouncing was noted here. But an important features of constrictive pericarditis was noted, and dilatation of the both atria was shown here. There is a tibial tear, and E by E prime ratio, E by A mitral inflow velocity, E ratio 2.1, and E velocity reveals 100 on. There is an annulus reversus. Actually, we know that medial annular, mitral annular velocity is usually lower than the lateral, but here reverse is seen, which is known as annulus reversus. And mildly impaired RV systolic function was noted. Inferior vena cava was visibly dilated, loss of respiratory collapse. And there is a hepatic diastolic flow reversal was seen in expiration. We know that there is also role of GLS to diagnose the constrictive pericarditis. So our patient reveals hot septum sign. That means the septum, the GLS preserved, but lateral or it is diminished. So the echo fissures, you must appreciate this. Echo fissures reveal the constrictive pericarditis with mildly reduced LV systolic dysfunction. So we, as we run a multidisciplinary hospital, so we called into the surgery department. So plan was radical pericardectomy. That was first actually, you know, that performed by German surgeon Ludwig. So our patient undergo radical pericardectomy, and after operation, the report was sent for delineation any fissure suggested tuberculosis, but there was no tuberculosis was noted, including the gene export was negative. And after operation, the X-ray patient actually admitted in our hospital yet. So after operation, the echo fissures reveal like that, and improve LV ejection fraction. Ejection fraction was 50. Day before yesterday, we have done the echo, and annulus reversus was corrected. We know that natural history after pericardectomy, 85% of the people can live 5 years and 57% live another 10 years. So on follow-up, he is feeling better than past. So my take is that constipated pericarditis is not a rare entity in our cardiac practice, especially in Bangladesh where tuberculosis is very prevalent, and we should communicate more in different discipline, especially where the diagnostic dilemma arises. Sometimes a very simple test like chest X-ray in our case can be very obvious to diagnose very early, though sometimes the pericardial calcification in 25% case is not obvious in. And echocardiography is an excellent modality to evaluation of the dyspnea, especially presence of ascites. And pericardectomy is indicated once the diagnosis of constipated pericarditis is made, and early intervention in patient with favorable functional status is recommended to improve early and late survival of the functional outcome. So, সবাইকে মে দিবসের শুভেচ্ছা. Thank you so much.